think I will give a big thanks for inviting me for the conclave.
Yes, sir.
Last year also I was here. And we have a eminent panel, very learned people, senior professors, and probably I have no role to talk here rather than introduce our Dr. Sahasrama. Long ago he was my student, he was my BG, he was my colleague, and he is considered as one of the most senior cardiologists. Very intelligent person. I respected him all throughout, and he will be able to guide you through the conclave. And I only remember the Cadillac Pharma of 1960s and 70s, when I had a colleague called Achyutan Nair. He was on Cadillac Pharma. Whenever we think about him, I remember him. He was walking with a bag in his hand he had no cycle. He went in the bus and made friend with all the doctors in Calicut. He was a very successful person. I request Sahasram sirs to talk and take over the rest of the proceedings.
Thank you, sir. Thank you so much. Thank you so much, sir. Yes, sir. So now all is yours. Yeah, you are going to just introduce. I will call them and introduce it. Make it very short and simple. I have used what cardiologist, I have used gynecologist, as you know, dermatologist and HOD, and just physicians.
Thank you.
Thank you, sir.
So, without spending too much of time on these introductions, I'll go off the topic. You already know Professor Bhadran. He was my teacher, and he has been the teacher to many of us. And every time he used to ask me questions when I was in gynecology. Today I got a chance to ask him questions. Thank you, sir, for accepting this. Now we have Dr. P.K. Ashokan. He is my colleague, cardiologist in Fatima Hospital. Tulsi. He is a general medicine consultant in Medical College, Calicut, and Dr. Sudhir, who is in the chest hospital and is a pulmonologist. So we have a very good panel here, and even though they gave me a large list of questions, what I discussed is, what I plan is they have given 60 minutes, of which 50 minutes will be for the panel discussion and maybe 10 minutes at the end for you to ask any questions if there are. I have prepared a list of questions which I have also given to the panelists, but there will be always cross questions. So maybe I'll go by order and then ask everybody. And some questions will have to be answered by two split departments. You all know about it. Is it possible to have these lights little dimmed or something? So disturbing.
Lights open. Both the lights open.
Those lights are not necessary. That's okay.
No,
No, that is okay. Sir, what special care is needed in a pregnant woman who has PCOS and diabetes?
This lady is certainly very lucky. Usually PCOS patients find it difficult to become pregnant. Over and above that, she
should be stopped, and diuretics, it be very careful in using pregnancy because it will reduce the uteroplasmic blood flow. Suppose it's a preeclampsia or in gestational hypertension. Were you to be careful in using again the diuretics, ACE inhibitor, and the preferred drug is nifedipine, hydralazine, and dopa. These are the drugs should be used. And same time, you have to see that uteroplasmic blood flow is maintained, and you are not using any harmful drug. And blood pressure should be controlled. When BP is above 160 and 110, then the complication rates are very high. And if there is any evidence of left ventricular dysfunction, then that's a time you have to use cautiously the diuretics. Otherwise, that it should be avoided.
So, Professor Badran, what would you advise? What special care you would give in a pregnancy-induced hypertension? Not a hypertensive patient becoming pregnant, but pregnancy-induced hypertension.
I give special care to every patient, not only for pregnancy-induced hypertension. But the point that Professor Ashwagan has said, see, I may also add labetalol, which is also a drug which is very useful. The difference between a pregnancy with hypertension and ordinary non-pregnancy is at what time you start the antihypertensive and at what level you start the antihypertensive drug. See, commonly what textbooks say is that you start in preeclampsia when the BP is 150/100. But in general, in practice, we start when it is 140/90.
So, because even treatment of hypertension, not pregnancy, we have brought out from 140/90, today we are saying 130/80 or even below. Thank you.
And also, there are some occasions what is called acute hypertension in pregnancy. That is preparatory to eclampsia. We may have to give intravenous antihypertensives, and in this context we are now lucky that we have got intravenous labetalol. For a long time we had got a lot of difficulty because hydroxyzine was not available, but now labetalol has come.
Thank you, sir. We'll switch on to pulmonology. Dr. Sudhir, what do you think? Does the maternal use of acid-suppressing medications in pregnancy cause increased risk of asthma in the offspring?
There are reports that there is a slight risk of the fetus of the mother who are exposed to PPI or ranitidine might develop asthma in later life. And these drugs are of course needed in pregnancy because of the increased abdominal pressure, and a patent esophageal sphincter would often force the clinician to use PPI and ranitidine to prevent acid reflux. So there is a very small chance, right chance.
Thank you. I'll come back to you again with other questions. Dr. Tulsidaran, do you have any special suggestions for managing diabetes in pregnancy? Already we have suggestions from Professor Badran, but I'm not talking of GDM. Diabetes, a patient is diabetic, becomes pregnant. Do you have any suggestions?
We are aware that the diabetes, degree of hyperglycemia and the complications related to maternal as well as fetus well known. So we try to get as tight glycemic control as possible. At the same time, it's better not to indulge them into hypoglycemia. It's also important. And diabetes management always starts with the lifestyle modification. Here, exercise of course should be advised, but as far as the dietary restriction is concerned, it's not be very stringent because we have to be careful about the nutritional adequacy. So, at that part, you need not be as stringent as in the non-pregnant women. But the exercise should be suggested, and of course the other pharmacological and the insulin and of now metformin is also equally suggested. So try to attain the good glycemic control as possible.
Then that doesn't mean that we should do it at the expense of this. Thank you. Question was to Shogun.
Heart disease. And the commonest valvular disease, the mitral stenosis. And any obstructive valvular disease, whether it's mitral or aortic, is actually dangerous in pregnancy because the mortality is very high. Even if it is symptomatic, moderate mitral stenosis should be suspected. In a severe mitral stenosis, to do mitral valvuloplasty or surgery before patient comes or early pregnancies. Then coming to the aortic stenosis. The commonest cause of aortic stenosis is congenital plus bicuspid. There are also severe aortic stenosis or symptomatic mortality is high. But these reasons low and rigorous conditions. So the mitral stenosis and aortic stenosis are the two common valvular heart diseases, and that should be tackled at the early stage.
But it's, do you see valvular heart disease complicating pregnancy nowadays as opposed to what we used to see 30 years or 40 years ago?
I do not see any case of heart disease because in my hospital there is no cardiologist. So, no patient comes to me.
Then I think you should appoint one as quickly as possible. There is a scope for a cardiologist there.
Those people who are working in baby or men's or in medical college will be able to answer your question. Not that.
Definitely the incidents have come down.
The incidence of rheumatic especially has come down dramatically. Because
Being a government institution, we do still see patients, but the incidents have drastically come down.
yeah, if at all we see
Most of the drugs are safe, but we need a caution while using corticosteroids and antihistaminic during first trimester. Certain antihistaminic like Allegra, that is fexofenadine, can be used with caution. The mainstay of treatment is inhaled bronchodilator and ICS. So of course, long-acting bronchodilator and inhaled corticosteroid for the maintenance, and ideally to avoid theophyllis, and short-acting bronchodilators for use of SOS use. But the use of bronchodilators, that is beta agonist, during last trimester may create some problem because these are as well as tocolytic agents. I think Dr. Badran would answer about that. The use of beta agonist during the last trimester of pregnancy, would it create some problem like postpartum bleeding or some effect of tocolysis?
which drug do you have in mind? Calicut.
Salbutamol does not cause any postpartum delays.
Salbutamol can be safely used as an inhaled agent. And when you said corticosteroids, you are talking of systemic corticosteroids or inhaled?
Usually inhaled.
Inhaled will it produce problems?
No.
No. It is, we should try to avoid systemic use of
The agent of choice.
systemic use of corticosteroids. Yeah, that would be important.
But whenever it is needed in an emergency.
Of course, emergency, the mother is more important than the baby. That's a victim, so it's you have to take.
Even in the first trimester, corticosteroids are relatively safe. But in the later weeks, we are straight away giving Beltesol 12 mg daily for 2 days for fetal lung maturation. 12 mg.
So that is not a contraindication as such. Okay, sir. So now we come back to you, sir, with the question: what common cardiac? I'm talking about. I will go to the next. Cardiac, not. I'm not talking of rheumatic heart disease or valvular heart disease. Other cardiac complications. Any other? Do you see commonly?
No, we are not saying it's
Common. In pregnant patients, do they come to you problem?
Yeah. Like any other person, they are also prone for heart disease and there is a risk factors. Then coming to the specific disease, one is pericardial cardiomyopathy. That's usually we see in the last trimester, maybe a few months after the menstruation. Here the pelvic dysfunction is severe, the recurrence is very high in second. This electronic function is fully recovered, the recurrence is still less, but this should be avoided, at least to avoid pregnancy. Then coming to the other interesting important disease is the coronary dissection, spontaneous dissection, electronic pregnancy. And other diseases like say hypertension is already we have discussed, hypertension. Then rheumatic we have discussed. So these are
Dissection you would think more in conditions like Marfan's.
And Marfan's is a very important thing. Let's say, if aortic root diameter is more than 40, you need to be careful. And there should go surgery the patient for surgery. So Marfan's, that's one thing.
What about pulmonary hypertension?
And pulmonary, so we are talking about the other complications, say severe pulmonary hypertension. That's also carries very high mortalities, then Eisenmenger syndromes. Then coming to the cyanotic.
Pregnancy. Of course, later on we said against pregnancy. And well, if the patient becomes pregnant, almost 100% mortality. But this was maybe decades ago. And I had at least 2 patients whom I said, this is dangerous, you should be careful, not become pregnant and all that. Then, of course, she changed the consultant. And then, after about 5 years, she came back to me. Again, Eisenmenger syndrome, no marked symptoms, etc. She said, I have a baby now 3 years old. So, and this happened twice, not the same patient, another patient. So after that, now I am very guarded when I give things like that. Because if you remember your Shakespeare, there are more things in heaven and earth than are thought of in your prayers. So we never know what will happen. Even though Paul Wood has said that Eisenmenger syndrome is dangerous for pregnancy. Maybe in his times it was so, but nowadays we don't know. So let us not put a blanket, a moratorium on such things, because we never know what will happen. So there may be some change coming later on also. So I just thought in passing, I remember when you said pulmonary hypertension. You want to add something?
Compared to the conventional disease, connective tissue disorders, harboring lung disease and heart disease, such girls are becoming pregnant and that really causes problem. Many of them are also having valvular lesions and pulmonary related lung related pulmonary hypertension. So that's the APLS. These are all issues nowadays more than the valvular disease.
And I will ask you the next question. Now, in practice of medicine, general medicine, do you see patients with diabetes complaining of gastric symptoms, gastroenterological symptoms? What are the common ones which you see?
Diabetes, and the most common I think is the drug related, the OHA related gastric symptoms or gastric symptoms are the most common. But there are specific diabetes related issues in gastroenterology like the GRD is comparatively very common in diabetic because some of the risk factors are common. And again, there are certain specific molecule related complications are there. Many of the GLP and analogs are the pancreatitis, non-alcoholic fatty liver disease quite common in diabetes, and of course the gastric paralysis related to autonomic neuropathy. So there are a lot of gastrointestinal related complications more probably in diabetic patients.
Okay. Then I'll ask the next question to you only. Can PPIs affect the absorption of any drugs or minerals or vitamins?
Definitely, because of the acid suppression, certain elements and minerals are particularly iron, and many micronutrients are definitely suppressed by the concomitant use of PPIs.
Yeah, what we find sometimes is they say they want a tablet for gas, and then we write a PPI. We write and say take it for 20 days or 10 days or something like that. The patient comes after 1 year only, and after 1 year they say I'm taking all the medicines, including that PPI, because our pharmacists, they don't tell that it is written for 20 days so you can stop it, because for them one drug means more money. So they keep on dispensing 1 year, 2 years. I have had patients who take PPIs for 5 years with an old prescription. They never come to the doctor and they keep on taking this. Of course, we do have in cardiology, we have certain indications where when we are giving aspirin, clopidogrel and all after PTCA, we give one of these drugs because we don't want complications like bleeding. But otherwise, when we write PPIs, they keep on taking this. We don't put a moratorium saying 20 days, 30 days or something like that. That is when they come later on with nutritional problems. They can come. This does happen.
In fact, we haven't kept that kind of a follow-up. Probably many of them are continuing
Yeah, that's what happens.
without even the principal drug. They may continue the side drugs.
That happens when you write a vitamin. They keep on taking the vitamin and stop the statin. Same thing we see. So because the vitamin is cheaper, but a statin is a little costly. Okay, so I am coming back to Professor Bhadran. Do you see pneumonia commonly in pregnancy? And is it true that pneumonia is the third leading cause of death in pregnancy? I read it only today. I never expected it. I thought there must be other causes of death in pregnancy. And to say pneumonia is the third leading cause, I don't know the reference there with me.
Passing the ball to Sudhir.
Good, sir. No problem.
Pneumonia, of course, the viral pneumonias are leading.
That may be there.
Like H1N1, it can go to any extent in pregnancy, like respiratory failure, ARDS. When taking pneumonia in pregnancy, talking about The problem is that it can cause respiratory depression, hypoxia, sepsis, and all that in a patient who is somewhat immunocompromised. So the most important thing is the fetal loss due to hypoxia and sepsis. Of course, this is the third important cause of death in pregnancy, and it's the most important non-gynecological sepsis in
So
pregnancy.
it is true to even it includes all the bacterial, viral, all
Of all
together. So that was news to me actually. I didn't know that.
HOD nowadays particularly should be stressed because
And it is more fatal.
but even more fatal compared to the younger population. Again, there do you give a double the dose of sultamivir for the pregnant ladies?
Or compared to the normal population. Okay, that's fine.
Symptoms are almost common.
Yeah, they overlap.
So usually there are chest pain, retraction, discomfort can occur in both conditions. You know that if you stimulate the esophagus, can occur on respiratory.
Exactly.
That way somehow some relation is there, the esophagus and coronaries. Then coming to the risk factors for both GRD as well as for, it's almost common. Like say it's more common obesity, obese people, hypertensive, smokers, and that way. So, but I think there's some studies have shown a slightly higher incidence of coronary artery disease and ACS in patients GRD.
Actually, there is a word called linked angina. Linked angina. Patients who have GERD, they also have angina. It has been found that during the pain of GERD, which has been proven to be GERD, the ECG changes may happen. And this is supposed to be due to coronary spasm which occurs along with GERD. So let us not, at least we should explain to our patients, don't pass off everything as gas. Because how people have always a habit of saying gas for everything. And that is how we have many sudden cardiac deaths in the population. Because they think it is gas. Sometimes it comes and goes. Then they think it is gas. I took one glass of water, it disappeared. Sometimes even they give a symptom that they belch 2 or 3 times and it goes away. And they think because I belched it is gas, it is not cardiac. But even angina after belching may disappear sometimes. So such things do happen. Now we'll come to Dr. Sudhir. What are the challenges in managing an obese asthmatic patient?
So thanks for the question. An obese asthmatic causes many challenges like he's a probable candidate for diabetes and metabolic syndrome. And then to enumerate that, he must be having sleep apnea, which can complicate asthma, gastroesophageal reflux disease, and insulin, like impaired glucose tolerance. So treatment is often difficult, whether it is corticosteroid or orally corticosteroid or a high dose inhaled corticosteroid, that can lead to loss of glycemic control. So the patient is at the risk of worsening of asthma due to many factors like sleep apnea, GERD, and when coming to treatment, he is a very difficult patient to get a proper treatment. Thank you.
Thank you. Now we will come to procedure, sir. A patient coming with a simple esophagitis, what would your line of management be? Not as a gastroenterologist, nothing invasive, just as a physician. Patient is coming, you are sure it is esophagitis, you are ruled out cardiac causes also. What will be your advice to the patient? This is something practical most of us face in our outpatient departments. Any specialty?
You should always take a history, whether a drug, sometimes swallow drug can remain halfway through. It can sometimes be chemical local irritation. So drug-induced esophagitis should always be kept in mind. Of course, any alcohol ingestion and in the previous or binge drinking, reflux esophagitis. These are the common causes of esophagitis and routinely seen. Of course, there are certain specific causes like if the diabetic patient, you have a specific candida infection, HIV patient, you have esophageal candidiasis. These are all specific entities. Other than that, normal in routine practice, I think it is a drug-induced and the chemical and toxin-induced the common. where you use a bland diet, liquid and anesthetic antacid, and sometimes I use the PPI for temporary relief.
Would you think that any of these antacid liquids are helpful?
In my practice, I think it is useful, at least to begin with.
See, one thing which we always forget is we ask the patient about drugs. There are certain drugs which can produce esophagitis like aspirin and NSAIDs and others. But there are, even if you take an ordinary simple any tablet, vitamin and so as he said, it can be stuck in the esophagus for some time. Now, many patients have a habit of just putting the tablet in their mouth and without even a sip of water they try to swallow it with saliva. That is a very dangerous thing. You should always advise the patient to swallow it with water and follow it up with 2 or 3 gulps of water. I always insist on that. The first thing I ask them is, how do you take the tablet? They say, I put it in my mouth and swallow it. There is no water, because they say, I am traveling in a bus, I take it. I say, don't take it when you are traveling in a bus, take it after you have come down somewhere. Because these are simple things which, unless we ask the patient, we don't know. So practical points which I have found out. And even for swallowing, I saw one small cartoon-like thing, video cartoon, where they show how to swallow a tablet. Actually, some people do it upwards, they put their neck upwards, put the tablet and swallow it like that. Actually, it is not what they say. What they say is you have to put the tablet over the water and then you bend your neck and then only swallow. Don't swallow with your neck extended. I found it very interesting. So I tried it the next day and what he said was true. That is, sometimes when we try to swallow with the neck extended, it regurgitates through the nose. And if you try to put the tablet in your mouth with your head flexed, it doesn't reach the throat. There are problems.
The initial deglutition process should start in the mouth. That propulsion should be there.
Yes. So that is very important. For that you need enough water. And the other thing is these capsules, gelatinous capsules, they have a tendency to stick. Sometimes if they put it directly into the mouth and swallow, it doesn't go down. It will remain there itself for a long time. And they feel that there is something here, some lump in the throat like feeling. And they have to wash it down with a lot of fluids. So these are things which we may have to practically advise. These may not be there in any textbook of medicine or anything, but these are things which you come out of experience. Okay, sir, one more question to you itself. In general, we're shifting the topics. In general medical practice, how common is osteoporosis? And what are the modes of presentation in your medicine practice?
Osteoporosis is relatively common in setting of many medical diseases as well as age-related. I think the commonest presentation is the low backache. That is how they usually come. The low backache has innumerable causes, but especially when you have a person above the age of 40 or suffering from systemic diseases, somebody on a long-term medication like corticosteroids, definitely this has to be kept in mind. And we have to evaluate with the X-rays or the DEXA or whatever it be. And it has to be one of the possibilities and the differential diagnosis for low backache. Again, of course, pathological fractures, simple, especially elderly, trivial, tipping on the uneven surface and falling, and not an instant to produce a fracture. So uncommon setting fracture produces, that's another presentation. So backache and pathological fracture are the common presentation as the osteoporosis in general medical practice.
An interesting point which I learned today was that metformin is one drug which increases bone density compared to many other. For example, we know that steroids increases osteoporosis, reduces bone density. But metformin is supposed to increase the bone density.
Metformin so is now given all the positive.
That was one drug which was used in India much earlier than the US thought of it. US never introduced metformin for a very long time because they thought it was very inferior drug. But unfortunately it has now gone to the top.
Every other day a newer and newer this one is added to metformin's basket.
Sometimes it happens, people get new things added to which they may not deserve. So that is also there. Okay sir, now I think I have been keeping Professor Badran quiet for some time. So we'll just ask sir, do you feel that from the pregnancy and the fetal aspect and all, What are the challenges of asthma in pregnancy? You get a patient in status asthmaticus. Of course, it may not be very common nowadays because it's well treated by them. But still, during pregnancy, if a patient comes with acute asthma, do you think it has any dangers for the mother and the baby?
Yes, certainly hypoxia will affect the fetus, especially if the oxygen saturation is less. That will certainly affect the fetus. So every attempt should be made to keep the saturation at a normal level. Otherwise, fetal oxygenation may be affected and the fetal distress may come.
So that is the most important.
Yes.
Beta-1 agonist.
I think that is also used as an nebulizer in patients with hyperkalemia. The side effect is used for benefit also. Because in our emergencies and all, when a patient comes, even before the moment we know that he is hyperkalemic, first thing is we start a nebulizer with this because that is the easiest to obtain. The other things may take at least few minutes because that is something like a lifestyle. And we'll come to Dr. Ashokan. Is there any difference in treating hypertension in a non-diabetic patient versus a diabetic patient? Only with regard to drugs. Non-diabetic and in diabetic, are there drugs which you want to use preferably or avoid preferably?
It's a little controversial.
I know.
The question is, and the question is when to treat also, which level, whether to treat at 140, 90 or 130, 85. Anyway, if there is a proteinuria or any end-organ damage or patient has associated cardiovascular disease, then you have to treat even at 130, 85, blood pressure. The drugs, coming to the drugs, and ARB or ACI inhibitor, the drug of choice in this situation. And these are the important things. Otherwise, 140, 90 is the blood pressure, the level at which we have to tackle.
Would you use diuretics?
Diuretics is all questionable. So the patient has hypovolemia, then we use diuretics. And whether to use thiazide diuretics, that's
will it aggravate the diabetes?
That is a controversial thing.
You see the European.
But guidelines says that we use diuretics.
Yes.
And thiazide is not contained.
No, if there is
as per the guidelines.
cardiac failure and all, there is
Yeah,
no
but
question.
trials have shown that it's a higher incidence of diabetes when you use thiazide.
In hypertension, will you, if it is diabetic with hypertension, will you add thiazides?
Thiazide can produce some degree of glucose abnormality, but that depends, sir. Suppose you have already used 2 drugs, BP is not getting controlled, and then as a 3rd drug you have to add a diuretic. In that context you have to use. But that diabetic control is not very, the statin, thiazide, that known to produce some degree of hyperglycemia, but not a major issue.
Okay, since I'll just ask the next question to you. In your practice daily, what diabetic complications do you see which can be managed as an OP taste? That is mainly for the general practitioners and others. In your OP, what are the I'm not talking of very severe diseases like peripheral arterial disease, which may need interventions and other things. What are the simple complications you see?
Peripheral neuropathy can be very easily picked up in every bedside because if you use the simple phenomenon and symptomatology, you can very easily, you need not go for the neuroconduction studies or anything. You can make a bedside diagnosis. And of course, if you are suspecting one microvascular complication, it is imperative that other complications will be there. You can always direct that patient for an eye checkup. You can always look for a microalbuminuria because these are all going hand in hand. And of course, many of the musculoskeletal complications can easily picked up and diagnosed in medicine. These are common complications that in the OP itself one can diagnose.
Yeah, that reminds me that looking at the fundus retina, not your fundus, not that retina, is very easy method. But do we do fundus examination nowadays?
Nowadays our postgraduates do not carry. Previously,
no, because I thought it was only with my postgraduates. So your postgraduates are equally bad.
No, we had a kit previously. Nowadays, sir, it is there in my bag. I will bring if required.
Oh.
As
So
well as,
they simply refer to ophthalmologist.
So that means if they don't carry a ophthalmoscope, they will naturally not have anything to test the smell, no tuning fork. Knee hammer, I think they will carry. Because I remember GK Warrior would throw us out of the window if we don't have this. And this is not a joke, it happened truly. I gave my ophthalmoscope to one of our postgraduate students to examine. He turned it like this, put the light on his face and started. I said, please give it back. I know how to do it. See, that is the status nowadays. But that is one of the best places you can just see the arteries directly in the body. That will tell you whether the kidney is involved, isn't it? Microangiopathy. That is very important. So, ophthalmoscopy, even though you don't have to get a consultation from an ophthalmologist for this. Right. And since that I am going to the next question with you only, it is only an extension of this question. Do you order investigations in patients who come with numbness and tingling? That is, you are clinically now suspected diabetic neuropathy. Do you order any investigations in that?
No, we have to look at the control status. Of course, we will ask for a HbA1c because if the diabetes status is not controlled, because that is very important. Other than that, I don't think there is sophisticated investigation from the peripheral neuropathy part is required, provided the duration of the diabetes and the pattern of the neuropathy is consistent diabetes. No more sophisticated investigations are required. But if you have a diabetic duration is not agreeing with the degree of neuropathy, and you have to rule out some other, then you, of course you have to order for it. Not to make a diagnosis of diabetic neuropathy, many investigations are required.
You have these nerve conduction studies, pedopodogram and so many other things.
It's not actually required.
What do you think is a good drug for that? For
Peripheral
diabetic
neuropathy.
neuropathy?
No. Peripheral neuropathy, there is no actually a single drug. Many drugs, whenever you have multiple drugs, none is as effective.
If you don't prescribe anything, the patient will change the consultant.
So we have the pregabalin, gabapentin, amitriptyline, all of them are being used with very
Amitriptyline is, I don't think, useful because they go to sleep and they don't get up for a long time.
In severe neuropathy, you give any extent, they will not sleep. Okay. So Isha sir will be able to comment on that. Yes.
My personal feeling is a better control of diabetes will be better than all these vitamins and sedatives. If you develop a severe neuritis, recently I had a femoral neuritis. Severe pain, lancinating pain, you can't sleep, you can't touch anywhere here. My way of treatment was a perfect control of diabetes. I think with that, usually it disappears or become better within 3-4 weeks. Till that time we will have wait.
What about the
You used to give, may be useful, but the real thing is you make a perfect control of diabetes, and that is better chance for a recovery. You can, in small doses there is no harm, you can continue for some time.
Incidentally, what is said about this control is very important. If the HbA1c should be properly checked. No point in checking what the patient says, fasting blood sugar and all. He will not take any food in the previous day and then bring a normal fasting blood sugar and he will go home and take laddus. See, our patients are, many of them alive. So we have to go by the HbA1c. But there has been some benefit which I have seen with this pregabalin drugs like that. The other thing is patients who are on metformin develop a B12 deficiency, isn't it so? So their patient is on metformin for a long time. I think we should give them beta methacobalamin.
combinations are available?
Now combinations are available, but I don't think combinations will be available. Then they take extra cost from the patient for that. It's better to give the drug when it is necessary. So that way it is important. Now I come switch to cardiology again. Now I am going to ask a tricky question again for you. You are a very senior person, you need such questions. What are the common problems relating to cardiology that a pregnant woman with a normal heart, normal inverted commas, complain of? How do we tackle that? That is,
Yeah,
patient has no heart disease.
always asking very tough questions, sir. So, especially pregnancy. This you are talking about hemodynamics changes. So you know that the common symptom is palpitation. If any patient, lady, palpitation, that means complaints of palpitation. That means there is a volume, increased volume overload. The palpitation should be more on lying down. It's not like palpitation of any other secondary to tachyarrhythmias, where a sudden onset and offset. But more on lying down, palpitation is common. Second thing is edema, because the volume overload is very high. Cardiac output is more than 50% of the non-pregnant status. And tachycardia is more on late stage of the pregnancy. And all the LV dimensions and RV dimensions are more. And these are the physiological things. So one is the cardiac output is more, and systolic stroke volume is high, and third one is the last trimester, the heart rate is more. So these are the three important things. So consequently the symptoms most common is edema, they can have a typical chest pain, and third one is the breathlessness, and all the way to thoroughly investigate and rule out the organic cause.
Yeah, of course, we have to investigate. I just said normal because I wanted to avoid all the...
But the common symptom what I come across is the palpitation, and second one is the chest pain and edemas. These are the symptoms.
And all these are more common in trainees.
Trainees.
Because they come to us, many often I get patients for echo. I'm sure you also. They come for echocardiography referred by somebody. The symptom, I just ask them what's your problem. They say either it's dyspnea or it is palpitation. And the heart rate is a little tachycardia will be there, invariably. And dyspnea will be there. Invariably, for the first time, their primaries are seen that they have enlarged abdomen, and that is what is producing the dyspnea, especially lying down and down. So I tell them this is all normal. Do you give them anything? Drug?
Don't give any drugs.
Yeah, that is the most important.
So that's certain things.
And I tell
this
them,
one condition where it's not used.
Absolutely. I tell them don't take any drugs, and I don't prescribe any drugs, and I tell them you go and talk to your grandmother, she will tell you. Because I don't refer them to their mothers. Mothers are a little too pampering. So better talk to the grandmother, she will tell you that there is something wrong. Now we come to pulmonology. How often do you see small airway obstructive? Because now I think the word COPD is gone. Because everybody says small airway obstructive disease. Is that in patients who are non-smokers? Smokers, of course, we expect. But non-smoker patients, in women, we see this small airway obstructive disease.
Airway diseases are classified as bronchial asthma, COPD, small airway diseases, as well as you can include bronchitis as well, because it behaves like an obstructive airway disease. Of course, small airway diseases are found in non-smokers who might be otherwise exposed to the noxious agents like household smoke, smoke from the biomass fuel. All these can contribute to small airway disease. The tricky part of small airway disease is that it will not become evident unless 50% of your small airways are gone. Then only it becomes manifest. Small airways are the area of the lung where the resistance of the airflow is least, is very less. So, the disease to become manifest, at least 50% of the small airway should be lost. So, identification of the small airway disease by the middle portion of the flow volume curve is useful. That's the only way you can find out and address small airway disease. Flow volume dupe. Thank you.
Thank you, Dr. Sudhi. Now, I'll start from you again because I'm coming to the final round of questions. In your opinion, what would be the preventive strategies you would advise? I'm coming to the preventive strategies. Will come through all of you. What preventive strategies you would advise in patients with COPD in the winter months?
The most important preventive strategy is to vaccinate pneumococcal as well as in every year influenza vaccine and every 5 year pneumococcal vaccine. Another thing is to properly treat his disease before the winter arrives. Before the winter arrives. Before the winter arrives, and if there are any chance of infection, airway occlusion, you have to address that. You have to get an optimum outcome from the patient. Optimum bronchodilator. There are a lot of agents are available which are now capable of taking care of the patient's symptom and give him a natural way of life. So treat him properly, vaccinate him, educate him, and of course ask him to don't go anywhere near smoking.
And crowds?
Crowd, of course. Stay away from crowds as well as infectious diseases.
Because recently I had one patient who said that I went to Guruvayur, stayed there for 3 days. I went and prayed. It was very crowded, no problem. But then for next 1 month he was suffering. I told, yes, viral. It's true. It happens in such crowds. And well, Tulsidaran, your opinion, a 60-year-old man, diabetic, preventive suggestions. Question will come. 60-year-old diabetic, what preventive suggestion? You will advise vaccination for him?
COPD or diabetic?
Just diabetic, not COPD. Maybe, may not be, but a diabetic patient will you advise? 60, 65?
We don't routinely advise any vaccination.
No vaccination. Pneumonia also you will not.
No, we don't.
In cardiology, would you advise this vaccination for any group of patients? 60-year-old?
If there's a heart failure, definitely.
Yeah, that's what. Any heart failure patients, whether there is COPD or not, should be advised both the vaccinations. Now, I'll come back to you. Now, the latest vaccine, pneumococcal is fixed, but what about this influenza vaccine, latest vaccine?
Latest is quadrivalent vaccine.
Yes. It was trivalent last year.
Yeah, quadrivalent vaccine. Yeah. The fact about influenza vaccine is that every year it gets updated.
Changes.
Every year it gets. So a patient needs to take, or an individual needs to take vaccination every year.
So last year's vaccine is no use this year. Last year there were 1 or 2 brands known as Influgen,
yes,
some other things. Those things are not available now. Actually, only today we placed an order for 10 vials of that new one, quadrivalent vaccine, which includes H1N1 also.
Yeah, H1N1.
Isn't it? So because we have
all 4 strains.
all 4 strains. So this time it is all 4 strains. One company has come with it, and I think that those of you who need it, because I know in our hospital even there are doctors, very senior doctors who are taking it. Every year they take the influenza vaccine and they have already had their dose of pneumococcal also. Because it's very important. You never know when you can be struck. So that is again heart failure patients, please do insist these patients should be having this influenza and pneumococcal vaccines. Well, I think with this we have come to almost the end of our discussion. Now I will keep the floor another few minutes. If there are questions or comments from the floor, I think you will have to pass the mic. Okay, you have it ready. And once that's over, we'll close the session for a vote of thanks. Senior people like Vijay Shankar sitting in the front, not asking anything or saying anything.
Sir, about the role of metformin in diabetes, can anybody elaborate a bit more?
Proceed and relax.
Yes, in pregnancy.
Is the role of metformin?
In pregnancy. A diabetic becoming pregnant and also in GDM.
As far as my knowledge is concerned, metformin can also be used during pregnancy. Previously, it was a contraindication. Now, metformin is an alternative. Other than that, should we stop insulin and start on metformin? I am not. Isn't there any guidelines like that, sir?
There are doubts that if we start metformin, the control may not be as stringent as we want it to be. and as we get it with the insulin. And also there are no concurrent studies to prove that whether the metformin will give rise to any teratogenic effect in the fetus also.
Previously it was absolutely controlled, but now there are many studies coming up. Metformin can also be used. Other than that, there are no guidelines telling that insulin should be stopped and started on metformin.
No, there are no studies to say insulin should be stopped and metformin started, but there are studies to show that metformin is beneficial in pregnancy compared to insulin. So if you are starting it in first time, if you can control with metformin, use that. That's what Professor Badran also said.
Yes. Dr. Narayanan knows the answer.
Oh, he's testing.
Yes.
Thank you, Dr. Narayanan. Any other questions?
See, I do not think that there are any reports that metformin leads to teratogenicity. It is a scheduled B drug. Of course, the classification of drugs as A, B, C, D, and
No, it is
have
approved.
gone. And the package inserts are supposed to give all the reports instead of the classes of them. And not only metformin, even dibenzoamide also is supposed to be safe in pregnancy. And FDA has not approved metformin, but the American College has approved it. So I think we can safely give metformin.
Thank you, sir. Any other questions? Yes.
Just a comment, because the many people nowadays, when he comes with fever, they get a course of the doxycycline. And doxycycline is a drug which is very notorious to cause esophagitis. Just to highlight.
Yes. Any antibiotic for that matter can produce esophagitis.
Yeah.
But doxycycline, because it's a preventive for this leptospirosis, we are giving it. Yeah. Any other comments? Questions? Okay, then we'll wind up. And thanks, audience. And I thank all my panelists, and I thank specifically Professor Ishok for introducing and being my co-chair. Thank you once again. I thank the Zydus also for having organized such a beautiful program.